What I'd like to do right now is once again invite my boss up, Mrs. Rosalynn Carter, to open up our evening session, one that we're doing a little bit out of character for us, and we're very excited about our presenters. Mrs. Carter.
Thank you, Tom, and welcome everybody to the Carter Center. I think it's been a great day, and I want to thank all the presenters who did. I learned so much today, and thank everybody who's been on the program, and I'm looking forward to tomorrow. And guess what I found when I got my dinner remarks out? The last page, the last sentence of my remarks this morning. I told you that Steve was the president and CEO of Shepherd Pratt Health System in Baltimore, Maryland, also a clinical professor and vice chair of psychiatry at the University of Maryland. Well, I've had the opportunity to meet all three of tonight's speakers at different times, and I'm so excited that they're all here together tonight to speak to us. But before I more formally introduce them, I'd like to acknowledge our funders, because we are so indebted to the funders. We could not do what we do here at the Carter Center without our funders and their generous support. The U.S. Centers for Disease Control and Prevention. Is there anybody here from CDC? They're here. Stand up. Stand up. We work closely with CDC. We're so great to have them in Atlanta. The Charles Engelhard Foundation, I think. Is there somebody here? The Commonwealth Fund. And SAMHSA, Substance Abuse and Mental Health Services Administration. I want to thank all of these. Well, to get back now to our speakers, Andrew Miller is one of two journalists who actually did an expose of our, called a series of articles called Hidden Shame for the Atlanta Journal-Constitution, exposing the suspicious deaths of the people in our psychiatric hospitals in the state. We owe him so much. He exposed this. The Department of Justice came, investigated hospitals, and now we have a great settlement. The Carter Center joined in as friend of the court, and the settlement that's transforming adult mental health and developmental disability systems in our state. You might hear more about that tomorrow. I'm not sure, but it's been so good. It didn't include children, so now we have to work on children. But I didn't hear. He is currently the CEO and editor for Georgia Health News, an independent nonprofit news organization devoted to covering health care in the state. And Dr. Howard Goldman is going to be with it, is going to be on the panel, is professor of psychiatry at University of Maryland School of Medicine. He is an old friend of our mental health program and has an extensive knowledge about the history of mental health policy in our country. I had a nice conversation with him at dinner tonight. And Dr. Ken Thorpe is with us. He's the Robert Woodruff Professor and Chair of the Department of Health Policy and Management in the Rollins School of Public Health at Emory University. He also is an excellent resource for us at the mental health program and is a renowned expert on healthcare reform. He was very involved in President Clinton's healthcare reform effort. Well, I'm looking forward to hearing that conversation tonight and the opportunities we face as we begin the implementation of the Affordable Care Act. So please join me in welcoming Andy Miller, Howard Goldman, and Ken Thorpe for our dinner tonight. And they will take questions after their presentation. Thank you. We're in for a treat.
All right, let's, are our microphones working? Yes? Okay. Thank
I
you,
hope they
Mrs.
weren't working before.
Yes.
We heard it all.
You haven't heard it all.
I'm very honored to be here. Obviously, you all have great stakes in our mental health system, and with the Affordable Care Act, it seems like everything is coming together in a very exciting time, especially for people in our field, plus people who are experts and journalists like myself. I mean, it's like the Super Bowl. And unfortunately, we're not going to know the score after 4 quarters. It's going to take us a couple of years probably to sort out all these changes that are going on, but that's why we have our experts here to help us. Can you hear me? Yeah. Can you hear me? Cynthia? Yes. Okay. Thank you.
I'm going to worry if you ask for mine to be lower. And don't say, what did you say? Sorry.
No, that's fine. So let's talk about the Affordable Care Act and what people need to know that might be kind of under the radar, but may be very important. Howard, you want to start?
Yeah, thanks a lot. It's great to be here. I always enjoy when I get to meet with Rosalynn Carter and with the whole crew here and Tom. I want to especially thank Joel Miller, both for having covered the basics on health reform and behavioral health, but also for giving me an idea about an opening line for giving talks, and that is, I have to find a way to make my remarks fit into your sexual fantasies. And that way, I think I'll only lose 5 or 10% of the audience. So I'm working on that still, Joel, but we can talk about it. You know, thinking about health reform, you know, we hear so much about what health reform is going to do, and I spend a lot of time writing about it and talking about it. But the thing that's really interesting to me now is also thinking about the things that health reform isn't going to do for behavioral health. And it comes in 2 categories of thinking about. We know, and we heard a lot today about the states where there isn't going to be an expansion in Medicaid and the implications of that for a state. It's pretty clear that there's a need for a continuation of the public mental health system, a state mental health system and a local mental health system. But I think it's important to also for us to recognize and prepare for the fact that there's a continued need for the public mental health system, even in places that have the Medicaid expansion, because the health insurance reform is really a pretty traditional medical model approach to health insurance, and that's a great thing. We need that. But there's so many evidence-based services that don't fit in that model. The long-term care services, social support services, things like supported employment, for example, that just don't fit. And if we don't keep at having a public mental health system, we are going to lose those services. In my ideal model of the future is that a public behavioral health system isn't just designed for people of limited resources. It can be a one-class system of long-term care and support services for everybody, for the benefits that are required that fall outside of traditional insurance. And I wonder what that would mean for our country to not only provide those services, but not have them tagged as services only for people of limited means in a second-class system, but actually a universal system of rehabilitative services. That's one of the things I think that we want to keep working on. We need to have some specialized behavioral health expertise continuing, even to guide Medicaid programs, even as certain services like inpatient care fall out of the public mental health system. Anyway, I wanted to share that particular vision because we've heard so much about all the great things that the reform will do. I think we want to keep our eye on the things that we are at risk of losing if we don't pay attention. Anyway.
And even in states that expand Medicaid, there will still be people falling through the cracks.
I mean, in the states that don't expand Medicaid, we have the people who have the greatest need will have nothing. I mean, that's really, people made that clear earlier today.
Absolutely.
It's clear. But it's somewhat less clear that even in places where the full model, if you will, of the Affordable Care Act plays out in the state, and there's an expansion, there are a set of services that are not going to fall within the standard benefit. Now, one of the things that I think could be a useful concession, even in states that don't do the expansion, that have Medicaid programs, is to take advantage of the 1915I provision. Forgive me, it's really hard to get that into your sexual fantasy, but the Medicaid 1915I provisions, for the first time, allow Medicaid to expand, to amend the state plan without having to demonstrate that it saves money, budget neutrality. And that's a way that state legislatures may be able to make a concession to the behavioral health field, even in places where the expansion doesn't exist. But services like supported employment, supported housing, wraparound services, services for kids, things that we've wanted to do for a long time but couldn't do in the Medicaid program, the ACA has afforded us this opportunity. And I think that groups of stakeholders in every state need to get together and try to make an appeal to their Medicaid system to bring in some of those very services that we know have a strong evidence base that people need that are never going to be covered by insurance as we understand it today. I think it's really important, and it's a great opportunity. That's because we're talking about money. If you've never heard Steve Sharfstein's talk about how he ended up getting into this field, I'll tell you a story. At your dinner table, sex was not taboo, but money was taboo. So my mentor, Steve Sharfstein, is guiding the way. I know it's in his sexual fantasy. 1915I. Is this polite after dinner talk? Is this all right?
Ken, I hate to kind of segue to you after that. But, talk to us about what you see as going under the radar, but we need to be cognizant of with the Affordable Care Act.
Well, sure. First of all, let me thank Mrs. Carter and the Carter Center for inviting me here. And thank you for your leadership in this area. You are a true champion for millions of people who really have underserved and needed mental health services. So I thank you for all your hard work in this area. Having said that, given what Howard opened, I have nowhere to go. I mean, seriously.
It's like following a dog at
I know. I think I've been doing talks for 30 years. I don't think I've ever heard an opening like that. So, but it was good. It was good.
Thank you.
Well, let me start with the good news about this. It's sort of a mixed review on sort of the ACA. The good news is obviously that we needed to provide a financial tool and instrument for people who don't have coverage to pay for services, and that's just sort of the fundamental thing that we needed to get done. We have within the next 10 years, roughly 60 million people who don't have health insurance coverage, many of them really in need of services that just don't have the capacity to buy it. And so the Affordable Care Act certainly moves us in the direction of providing a financial base to allow people to pay for services. Challenge is that even sort of in the best estimates that within the next decade, roughly only half of the people who are going to be uninsured over the next decade are going to get coverage. So to Howard's point, we're still going to have about 30 million people who don't have health insurance coverage. They're going to have to find alternative avenues and channels to get into the provision of health care. So having that safety net system in place, insuring it up, and having a financial base to make it viable is going to continue to be really, really critical issue. So I want to make sure, and I know nobody in this room has the illusion, but I think people sort of think that we passed this law that we're going to get everybody covered. No. I mean, we're going to have a substantial number of people who are left out, choose not to buy coverage, and so we're going to need a strong, vibrant safety net. I think the second point that I'd make, which I completely agree with here, is that with the Affordable Care Act allowing the states to pick a benchmark plan, I think in most of the states that did this, they really picked plans that are still sort of vintages of plans from the 1950s and 60s and 70s. And they're really not plans that are forward-thinking, they're not innovative, they're not moving the system in terms of the delivery services where we need to bring them. And that's going to be a real problem. I think that that's a challenge that, particularly in terms of mental health services, that we have to continue to fight. And to Andy's direct question on the third issue, to me, when I think about healthcare reform, obviously I think about expanding coverage and building a financial capacity for people to buy it. But when I think about healthcare reform, I really think about it in three different areas. If we are really going to reform healthcare, we need to do three things. We need to have a system, and it's not just on the insurance side, but we need to have a population-based public health system that does our job of averting disease in the first place. We need to improve our ability to detect disease so we can intervene earlier and improve clinical outcomes. And we need to have a system that really engages and works with and manages people that have multiple chronic healthcare conditions. It cuts across silos of care that we currently have. That's the future, to me, of healthcare reform. It's not just the financial base, but if we're really going to reform healthcare, we've got to move in those three areas. And let me just focus for a second on that third point. And I think that the future of this has got to figuring out ways of how we can integrate care provided to a patient. And I want to make sure that when we talk about healthcare reform, we're thinking about people. In Medicare, I'll give you an example in Medicare. In Medicare, half of the Medicare population is being treated for 5 or more chronic healthcare conditions. That accounts for 80% of the spending. That's where all the money is. And a typical person who's driving the growth in Medicare spending is a 75 or 80-year-old person who's overweight or obese, who's a hypertensive diabetic with bad cholesterol, pulmonary disease, back problems, asthma, and is depressed. Right? That's our patient. So we need to have a system that can provide comprehensive services that cuts across silos, that really addresses all of those issues. The mental health issues, the chronic disease issues, the cardiovascular issues, the acute care issues. So that's, to me, that's the challenge that we face in the future, is how do we build a delivery system and prevention system that really does a better job of working with and providing better quality care to patients. Providing the financial base was a start, but we have a lot of unfinished business if we're going to really improve how we do healthcare for people who are really in need for healthcare services.
I think that there are some experiments out there, actually more than experiments, they're actually happening, where you have things like accountable care organizations, you have patient-centered medical homes, you have, in many practices, you have integration of primary care with mental health services. How hopeful are you of these efforts that they can broaden and actually help people and bring costs down at the same time?
Well, I'm optimistic. I sort of have go on this at two directions. One is that the Affordable Care Act put a lot of money into doing pilots. We have thousands of pilots. It'll take 5-10 years to figure out what the results are from the pilots and whether they worked or didn't work and whether they're even sustainable. I think that if we're going to be moving toward the systems that I just described, we have to change our mentality from one of a better balance of pilots and implementing what we already know that works. We have an enormous amount of data, experience on things that work. We know we have programs that we know, like the Diabetes Prevention Program, that is a great job of slowing the progression of diabetes, and with it, comorbid chronic diseases, including depression. We know how to engage and work with patients that have multiple chronic health care conditions, doing transitional care, health coaching, medication therapy management, health literacy issues. We know these things work. We need to implement them. We need to have a mentality of a sense of urgency on this issue to really implement best practices and move along. And yes, do pilots on targeted areas where we don't have information. There may be information places where we need to have some targeted results. But I guess my view of it is twofold on the pilots. I have pilot fatigue. We are not one pilot away from a miracle. I mean, seriously, we have so much existing data on things that work. We just need to have the leadership to put those things into place and really start transforming the system that really meets the needs of patients that have multiple chronic healthcare conditions.
Howard, what about the integration issue, mental health and primary care? How do you see that playing out?
Well, just to pick up on Ken's point, there are a number of well-tried models for the treatment of depression and other mental disorders in primary care settings. There are some models for providing general medical services in community mental health centers. The work on collaborative care, treatment of depression out of the chronic disease model that Ed Wagner developed, but that Wayne Caton and Jürgen Unitzer have modified for depression has been replicated. The evidence is really extremely strong. And I realize that the Brave New World is thinking about different ways of financing that and getting away from a fee-for-service approach, which I support. But we could do a lot better even in a clunky old fee-for-service system if we paid for services that are elements of these models as a fee-for-service, if we'd get rid of some of the antiquated roadblocks we have about how we bill for services. If the diabetes area was able to get a diabetes nurse educator paid for in fee-for-service, it's really hard to see why we can't get a clinical nurse specialist manager to work in a collaborative care arrangement, why we couldn't get a psychiatrist consultation paid even if there's no face-to-face visit. You know, a small degree of creativity, even in the antiquated fee-for-service system, could go a long way. And I know it's a shout out to Ben Druss at Rollins. I have a new integrated care program. The American Psychiatric Association has been very active in thinking about strategies, and a work group that I'm chairing for the Board of Trustees, an element of it in terms of health reform is training psychiatrists to know more about what practice in those settings would be like. We have a big mission, even with the existing workforce, to train them in those models, but the time is now to do that kind of work.
You mentioned a little bit about workforce and how we deal with that. That's going to be a big issue, both in mental health and also general physical health. What do we do when we have all sorts of new people, hundreds of thousands, millions of people with coverage? I mean, how are we going to meet their needs for a provider?
Well, again, I think it just goes back to this notion of sort of interdisciplinary teams. I mean, a lot of what we do in healthcare doesn't always happen in the physician's office. A lot of it happens in engaging and working with patients when they're at home. And a lot of the expertise that is needed to work with patients to keep them healthy, keep them out of the hospital, cut readmission rates, cut emergency room rates, do a better job of transitions across the system, are really done by nurses, nurse practitioners, mental health workers, social workers, nutritionists, pharmacists, and so on. So we need to more directly engage them in working collaboratively with physicians and hospitals in managing and working with patients. I mean, we have an enormous workforce out there that's very well trained in doing that. So we need to find some way of sort of building better integration between providers, physicians, hospitals, and really sort of other healthcare professionals that are really experts in preventing and managing chronic healthcare conditions.
Yeah. In behavioral health, in addition to that, we have a growing experience with peer supports and people in recovery delivering services to other people in recovery. This is an important way to expand the workforce. There's a growing evidence base. We started reporting on it. I think it was Larry Fricks who reminded me. I didn't see Larry here, but when I was in Savannah talking to the boards a couple weeks ago, Larry reminded me that we worked really hard to get a little evidence about peer support services into the Surgeon General's report in '99, and the evidence base is slowly growing, and it's a very important avenue for expanding services as well, for expanding the workforce.
Right. I mean, Joel Miller mentioned inner cities, rural America, where there are no mental health providers. Howard, how do we deal with that situation? Is telemedicine an answer?
Yeah, the frontiers of telemedicine are being pressed, even in our small state whose virtues were extolled by our director, Brian Hepburn, earlier today. He's pushing us to do more with telemedicine, and we're doing more in our evidence-based practices center at the University of Maryland in distance learning strategies, in training people to do evidence-based practices. You know, we have a reservoir of talent that are tied up doing antiquated interventions that we just need to retrain to do more effective treatment. That would be a start even with the existing workforce in terms of increasing our effectiveness. And if the public mental health system depended on FaceTime with a psychiatrist, it's a desert from that perspective. We learned many, many decades ago about the need to use a broad array of professionals and paraprofessionals. And what's exciting really in the recovery era is to see the large number of people in recovery who could make contributions to care.
I was struck during the conversations today, during some of the speakers' talk, about the states that are expanding Medicaid versus the states that aren't. And it's a totally different dialogue, a totally different point of view. And I'm wondering, 25 are expanding, 25 aren't, at least initially. Are we going to be seeing totally different systems, like almost two different Americas, in states that don't expand versus states that expand?
Well, I think so. I mean, again, there's sort of two aspects of the states that don't expand. Obviously, most of them are in the South, red states. But also, this is the real challenge, is that most of them are in states that have traditionally relied on not on Medicaid to provide coverage for low-income populations, but on a public health care system. Take Texas, Georgia, Florida. These are states that have relied on public health care systems, public hospitals, as an alternative to doing Medicaid to provide care for low-income patients. And I think that the challenge is that I think that those states are kind of fooling themselves into thinking that they have where's the money going to come? You know, where is the ongoing sustainable funding going to come to shore up that safety net to provide care for those populations? So yes, I think that you're going to have a set of states that are basically, stuck in sort of an old-time system where you have people with insurance and people getting coverage through a public health care system, a public hospital system, and other states that are going to really be able to innovate and really reinvigorate how they deliver services comprehensively to everybody, because they're all in the same system. So I think you're going to have states that have very, very different systems that persist for long periods over time.
Yeah, I mean, Ken is absolutely right. And if you focus in just on behavioral health, I think it's important to remind us that unlike general health services, every state has a State Care Act that obligates the state for the public provision of behavioral health services. Now, they can expand or contract that, but as far as I know, the passage of the Affordable Care Act has not led a single state legislature to repeal its State Care Act. So it could theoretically be a seamless experience being without Medicaid. I mean, many states shifted to Medicaid, but 30 years ago, I remember traveling around from state legislature to state legislature in a project that NIMH sponsored with the Conference of State Legislatures. And these state legislators would ask me, well, how are we going to be able to expand our mental health services and get Medicaid without having to pay any state share? And those are the same states that didn't want to expand Medicaid, but they do have a public mental health system. But it could easily die if we don't keep at it, to keep it alive, particularly in those states that decide they don't want any part of the Medicaid expansion. We can continue to deliver services.
What about, one question I just was struck by. If I'm a young physician coming out of med school, or if I'm a young nurse, am I going to want to go to a state that has full expansion and is working really well versus a state that is not? I mean, would my selection or my choice be influenced by that, do you think?
I mean, it really depends on the structure of the Medicaid program. I mean, the real key in terms of Medicaid is you've seen one. And so, the Medicaid program in terms of the payment rates in Maryland or New York are very different from the Medicaid program and the payment rates in a state like Mississippi, Alabama, Georgia. So, it's one thing to expand coverage, which is a great thing, and I think all the states should, take advantage of that because it's just a terrific way of really shoring up the safety net. But a lot of it just really depends on, the state Medicaid program and its design.
Yeah, I guess it depends on whether young doctors and young nurses want to practice in a place that would cut off its nose to spite its face. It's really quite remarkable how strongly people cleave to a really, really bad financial situation. Mm-hmm. What is wrong with the picture that you turned down in your state full federal support for 3 years and a matching rate of 9-to-1 that's unprecedented in Medicaid up until now, and you have a Medicaid program that you use, and do it in the face of losing your disproportionate share payment? That's something Joe Parks has reminded us about in behavioral health care. It's a losing proposition all the way around. And oh, by the way, you also aren't covering people in your state who lack insurance and have limited income. So if I'm a young doctor or a young nurse, at least the kind I used to like to practice with, I would just avoid those states entirely, but that's probably not practical.
Well, yeah, I think it's the only time states actually have turned down free federal money. They take it for roads and other things.
Two things that were pointed out. One is if you look at the distribution of federal revenues generated and federal payments, that most of the places that object so much to the expansion of government are net winners with respect to the balance between receiving and generating federal revenue. So it's clearly ideological. The other thing I'd remind us is that not every state agreed to the Medicaid program when it was first launched. And I still remember when Arizona didn't have a Medicaid program up until they created Access maybe only 20 years ago. So, it's going to take time. One thing about history, I spend my time being a visionary looking in the rearview mirror. And it's usually pretty good, but you don't want to be around me when I'm driving most of the time. It's going to take us time to see how this thing really plays out. States have played this silly game before of resisting change.
How does the ACA fit in with the parity movement, Howard?
Yeah.
How do you assess that?
Well, I've talked on a lot of occasions about how impressive it's been to see the mix of really fundamental reforms and incremental changes. How the idea, as long ago as President Kennedy had the idea that health insurance should be the same for people with mental illness, set this forth in 1962, and then he made one incremental change. He directed the Civil Service Commission to have the health insurance pay for behavioral health care the same way. But it took all those years, 50 years, of little tiny steps in federal employees insurance and changes that were made as a result of the National Plan on Chronic Mental Illness that came out of the Carter Commission and the Carter administration. Little changes to Medicaid improvements, little changes to Medicare. When I started, the Medicare benefit for behavioral health care was $500 of services. The patient paid 50% of that. If they were lucky, they got to spend $250 of their own money towards the $500. After that, they had no benefit whatsoever. That changed slowly, and little changes in the budget reconciliation. And things added up so that in 2008, we had the federal parity. In 1996, we had the federal parity law. We thought it was only a rhetorical victory. But think about what a rhetorical victory it is to have no annual limits and no lifetime limits. Turns out that really saved people from catastrophic losses. But we didn't quit. We said we have to have full parity. We got that in private insurance in 2008 and Medicare in 2008. And it was like the perfect alignment. It's like it wasn't even a consideration. Oh, if behavioral health is going to be included, of course it will be at parity. And we're waiting for this final rule to see exactly how it's implemented, because we have to hold everyone accountable that the law will be implemented the way it was clearly intended. But it's been a very exciting thing, because the 2008 law said You have to have services at parity if you have behavioral health care. The Affordable Care Act says you must have behavioral health care and have it with parity. That is just the perfect next step. But think about how long it took. Richard Frank, my good friend and colleague, and I wrote a paper with Steve Sharfstein 30 years ago about parity and equity. And we were writing that scarcely 20 years after President Kennedy had articulated it. But if you keep a vision in mind and take advantage strategically of little steps that are afforded to you politically, we can make really progressive change. It's really an amazingly optimistic thing in a world where incremental change has a bad name. And I think that's really an ill-advised kind of association.
We have time for questions. If any of you want to ask our experts something that might be on your mind, feel free to raise your hand and fire away. Yes, ma'am.
Thank you for your great comments. I really enjoyed hearing them. A couple of people have talked in the larger debate about how we don't have a healthcare system, we have a sick care system. And knowing that the ACA does lend itself to some of the prevention and wellness areas, what do you see as the turning point for those who might be on the losing side of prevention, and how we might overcome an obstacle?
Ken.
Well, I guess my approach to this, and this is really, I think, a sad commentary about how health policy works in Washington, is that many, not all, but many of the major changes that we see in healthcare really flow through Medicare. Because it has just ripple effects throughout the entire system, the private system, Medicaid, and so on. And the unfortunate fact about Medicare and the way it's dealt with in Washington, it's not dealt with as a health policy issue, it's dealt with as a budget issue. So all of the discussion about changing and saving money in Medicare is a budget issue. It's not a reform issue for the most part. So I would sort of love to engage and challenge everybody in the room to sort of do the following. One is that if you present the data to members and people in your community about what the key drivers of rising healthcare spending are, because then their ears open, because it's money. And in Medicare, there's sort of two facts that are really important. One is that since 1985, 80% of the growth in Medicare spending is due to a growth in the prevalence of chronic disease, much of it potentially preventable. Two is that 80% of the spending in Medicare is linked to patients that have 5 or more chronic healthcare conditions, including mental disorders. And for 72% of the population, Medicare, completely unmanaged, completely uncoordinated. So if you sort of frame the budget discussion around facts, I think the way out of this, because it's got to be a money discussion, unfortunately, the way out of this is to say we really need to go back to where I started, say if we're going to solve this as a long-term problem and pulling costs out of the system and improving quality, we really need to do those three things I said. We need to have a health policy discussion that's not just a health insurance design issue, although clearly parity is critical to this. I mean, why would you want to have a different set of insurance rules for a patient with 6 chronic conditions, 1 mental health, and 5 chronic conditions that are different? Doesn't make any sense. But if you go back and sort of frame the debate around the money and where the opportunities long-term are for saving, it goes right to the issues of aversion, detection, and management. It goes back to the broader toolkit of population, prevention, health, redesign of the delivery system, that we just need to move that discussion forward faster. That's why my frustration with the pilots is that we delay that for a decade until we get the results. We're not going to get a magic miracle result out of 10,000 pilots that we funded. We have the answers on how to do this in front of us. We have great models of care delivery, of how to really work with patients that work. We just need to get some inertia, some leadership, and some focus on changing mentality from piloting to implementation, but tying it back into the money, tying it back into the dollars. And that's the unfortunate truth about how Washington works is that big changes in healthcare don't work unless they're built into the structure and construct of the budget.
Yes.
Hi, I'm Gail Mackley, and I'm the Executive Director of the Licensed Professional Counselors Association. And I just have one question for the panel, because I feel like I'm hearing the words of wisdom from the wisdom leader. In the United States...
A lot of wisdom there.
It's a fantasy, I'm sorry. But at this time, across the United States, we do not include in our Medicaid program 250,000 licensed professional counselors, licensed mental health clinicians across the whole United States. 250,000 providers are excluded from our program. So how are we going to address this with Medicaid to get these providers included? We talk about parity, we talk a lot about parity in the insurance industry, just like you talked about the separate models. But here we have a whole group of providers, 250,000 mental health professionals, and they're excluded from Medicaid. How can we bring people into systems and serve them if our providers are excluded? I don't know where to go with this.
Well, one opportunity, one good thing about the Affordable Care Act on the delivery system side is, and we're doing through these sections, is Section 2703. Well, reread Section 2703. Says
Still excited, Steve?
Yeah, see.
Tell us what that is, Ken.
Steve, he was doing cartwheels. You missed that. Section 2703 is for Medicaid health homes. And what it says basically is that if a state Medicaid program gets a state plan amendment and uses multidisciplinary health teams, including the types of providers you're talking about, to work with hospitals and healthcare professionals to manage across the whole spectrum of care, these are salaried individuals. So Vermont does this. I mean, several states do this. Well, Georgia's Georgia.
Better lobbying.
Better lobbying. But I'm just saying is that there's the opportunity through the Affordable Care Act, through Section 2703, that if you do care coordination using interdisciplinary health teams to work with patients, you get a 90% match, not your usual state match, for 2 years, and then it's matchable beyond that. And there are several states that have taken the feds up on that and moved in that direction, Missouri, Minnesota, among others. It's a great model. It's a better way of providing care. It gets you out of sort of the billing issues in terms of CPT-4 codes for different types of professionals. You can build the right interdisciplinary teams to really work with and provide the best quality care for patients. That's a way that a lot of the sort of forward-thinking state Medicaid programs are going, is using this Section 2703.
But it still doesn't address Medicare.
Doesn't?
It's not addressing Medicare. We do have to support Medicare.
No, I understand that.
Social workers in Medicare, but we have 250,000 mental health professionals not included in the program.
No, that's true. In Medicaid, once we get to the discussion about reforming Medicare, the bulk of this discussion about how to reform Medicare has got to be on how do we reform the 72% of the people in the original Medicare that don't have any kind of really lifestyle prevention, care coordination services that use these interdisciplinary health teams. Now, we've developed proposals, this group I run called the Partnership to Fight Chronic Disease, that would build this type of team-based care into original Medicare. So we just need to get the Congress off of the Obamacare repeal. We need to fix how we pay physicians. We need to get through that discussion about the SGR. And then we really need to get to these big structural issues about how we're going to sustain Medicare over the long term, because I got to tell you, unless we make these types of structural changes in the program, the way that the Congress is saving money in Medicare for the next 10, 15 years is not sustainable. We cannot just continue to cut payment rates to providers. That's not a sustainable long-term strategy. It doesn't take a dollar of cost out of the system. It just simply is redirecting money from the federal budget someplace else. But we need to have that discussion. That to me, like I said from the beginning, that's the essence of healthcare reform, is how do you rebuild and build a delivery system, engaging professionals that know how to work with patients with multiple chronic healthcare conditions in a more efficient and effective way.
Yes, sir.
I think, what role do you think consolidation will play in the continuing evolution of healthcare in general and behavioral health in particular? I mean, Medicare, fee-for-service, Medicare and Medicaid are about the only place in the world you see the government will buy services from one producer at a time. You can still get a check for your Medicare service as an individual provider. You can still get a fee-for-service Medicare. I can set up my own shop. Nowhere else in government do I know I can sell a service in that scale. What role do you think consolidation is going to play in the next 5, 10 years? Will government still be buying services one provider at a time?
5 or 10 years, I don't know if it's a 5 or 10 year scenario, but there's no question that, it's just a chicken and egg thing. Everybody up there is focusing on sort of 3 things in terms of the long-term Medicare reform. One is payment reform. So I think that there's almost as much unanimity you're going to get in Washington, consensus that we've got to transition away from a volume-driven, fee-for-service, silo-based approach. Given the diversity of conditions that Medicare treats, it promotes the type of separation of services and poor care. I think it's just a matter of how fast they go. They are going to continue to expand using bundled payments. And there'll be a lot of debate about how that's structured, whether it's just focusing on post-acute care bundles, integrating acute care and post-acute care, and so on. That's going to happen. It's just a matter of the rapidity of how fast that's going to push out. I think, as groups get more efficient in doing the accountable care organizations, which really, to be successful, you got to not just have legal frameworks linking providers, you got to change how you deliver care. If you're not changing how you deliver services, these things will just go belly up. So I think that, it's the unfortunate truth of, about not only Washington, but the healthcare industry, is that we have the healthcare system that we incent, that we pay for. And the way we pay for services has a huge impact on how services are delivered. Until we change the way that we pay, so that we promote integration, we promote whole person care, team-based care, we actually promote prevention. We have a system that not just pays for the amputation for the diabetic, but we actually have a system that really wants to prevent somebody from getting diabetes in the first place. So we need to change the payment rules. That is happening. That was a big part of the House Energy and Commerce proposal that came out last week that would have reformed the physician payment rules. But it's just a slow trudge to do it. But everything's directionally going in the right way. I think it's just a matter of how fast we're doing it.
Yes, sir.
When this panel started, I kept thinking to myself, how did Sweden do it? When I was in Sweden in 1963, my taxi driver just went crazy explaining to us how wonderful his government was, that they paid for all his medical care. And as you continued to talk about the fiscal concerns versus the philosophical concerns, I began to understand my question and the answer to my question. The country has to buy into the idea that every citizen needs to have health care payment with some equity. We haven't done that. And you have repeatedly talked about the fiscal issues, and I think it's important because for people who aren't paying attention to what is driving the non-system, they aren't looking at that point. I was very, very impressed with the kinds of stuff that has gone on in this panel regarding what it would take to get this country to put themselves, the whole country, behind the idea that every person needs to have help.
Yeah.
I just want to comment vis-a-vis Paul Fink's comments, and that is I do a lot of work with young investigators in Central and Eastern Europe. And one of the highest values they have is in a word that's almost unknown in English, and that's solidarity. You know, when I explain to them that it only has this very rarefied meaning in this country, referring to the labor unions of the almost distant past, and it's such a vibrant word for them to speak about how they feel about each other. It was very telling to me, and I think it speaks to your point, Paul.
We have time for one more question. Yes. Yeah, right. Yes, ma'am.
So one of the things that's also clear to me is, at least so if I speak from Oregon, we actually have two essential health benefits. We have an essential health benefit for the Medicaid program and for the commercial program. And I'm just wondering if either of you see a moment in time when we actually will have an essential health benefit, whether for a state or for the country. Because right now we still have a disincentive for people who have chronic mental illness. If they're on the Medicaid, even the Medicaid expansion, stay there. Don't earn that extra dollar, don't end up in the commercial market, because it's a different benefit structure. And just so if you could speak perhaps to those challenges and where you might see opportunities looking forward.
There are a lot of discontinuities in the design of the system, and it is a serious problem in its design. But one thing's very different and positive, especially in places that have done the expansion, and that there was the earlier question about prevention. I don't do so much universal prevention work, but I do a lot of work these days in the design of early intervention in psychosis programming. And the way we had organized our mental health system excluded people before they became disabled from reimbursement, because your entree to Medicaid was through the SSI program, the Supplemental Security Income Program. And the Medicaid expansion changes that in a dramatic way. And states will need to, the public mental health system has to open itself up to doing more early intervention work. And now we have, even in those that are driven by Medicaid, an opportunity to use Medicaid to pay for it. But these benefits are just inherently different. I mean, the services that I was describing are much more likely to be covered by a Medicaid program than certainly by Medicare or private insurance, which, as Ken points out, really is a 1950s, 1960s health insurance model. But I am hopeful that we are moving toward better benefit design, but we have to get the balance right between the insurance-funded system and the directly, categorically funded system that we can't let die.
Well, I've learned a lot here, and I thought I was a healthcare expert, but gentlemen, thank you for your time and your expertise and your comments.
Thank
Let's
you,
give them a good hand.
We add our thanks as well, and Andy, to you for keeping the conversation going. This panel was a bit of a deviation from how we normally do the evening speaker role, and we had a lot of discussion about whether or not we should do it. And one of the parts of the discussion that we had was, how do we do it without duplicating the work that was done during the working sessions? You achieved it, gentlemen. Thank you very much. Now, on to the mundane. I think we've all had a full day, even though it's a half day. I know my team sure has. Want to once again thank everybody for their tremendous contributions and really riveting discussion. It got us to another level of discussion that we need to get to as a nation. Tomorrow, the buses will take everyone back to tonight they'll take everybody back to the hotel. And the buses, you will get through this door, up the stairs, out the door. At the executive office entrance. So it's not by the museum, it's that door. And we'll have staff around that can help direct you. The luggage was moved to the executive office entrance, so find your luggage, and please don't dally and don't wander. We find ourselves chasing people all over this building. This is a large building. It's not intuitive. If you don't know it, you're going to get lost, and we have to find you. So please, stay with us on this one. Buses will depart from the hotel tomorrow at 07:45. For you civilians, that's 7:45 in the morning. That's real early. So no more partying tonight. The party's over. It'll bring you to the meeting place tomorrow. It'll be back at the chapel. The chapel was the building where we held everything today. So that about does it. If I get my team, have I gotten everything? I think that gets it. Everybody have a nice evening, a restful evening. Big day tomorrow, busy day tomorrow. Go, go, go. I look forward to seeing you tomorrow.